And really this will be very informal. I mean, we're a small group, so you can interrupt, you can ask me questions. If it's something I'm going to cover a little bit later, we can always skip around. It really does not matter. A lot of basic information, not too scientific so that it's over your head, but just enough that everybody can know what to do on a daily basis to keep their bones healthy. Most of us think about bones as inactive structures in our body, that they are just the skeleton or the framework of our body, but they are not. Bones are very active metabolic structures. And we don't think about it until somebody gets osteoporosis and they think, oh my goodness, how did that happen? And how did I get that fracture? And oh, that's not supposed to happen to me. So this is really just about defining what osteoporosis is, the things we can do to recognize when we might be at risk, and what we can do to help maintain or improve our bone density. So what is osteoporosis? Osteoporosis is not thin bones. Osteoporosis is the demineralization of the microarchitecture of our bones, and it decreases the mass of the bones, so the bones become less dense. So it's a good thing we have our low-tech things. And an artist I am not. I don't have any of that left brain part of me. But when we talk about bone density, and I'll try different markers if I don't get the right one. If we think about a vertebrae as the basic structure, I like to use a vertebrae because of the way it's made. It's not a long bone with marrow in the middle. What it's made up of is tiny little tendrils of bone all through, going all in different directions, and that's what gives it structure. It looks like sponge candy. If you take sponge candy and cut it in half, has everybody seen sponge candy? That's what the vertebrae looks like. So all of those little tendrils are made up of calcium and phosphate, which is the building block of our bone. So when we get osteoporosis and we start to demineralize, that means we start to lose the calcium and the phosphorus out of our bones. Where do we lose it first? We lose it from these tiny little tendrils in the vertebrae. And as they get weaker, they decrease the strength of this structure, and that's how we get compression fractures. And they are the bones that are most likely to show signs of osteoporosis first. Bones that are made like this. So vertebral bones, your sacrum, your pelvic bones, the femoral neck. So the neck of the femur isn't quite like the long part of the bone, but in here, when we get osteoporosis, when you get that same weakening of these trabeculae, that's how you get those hip fractures. So that's the basic concept of the definition of osteoporosis. So how do we diagnose it? Do we just look at an x-ray and go, oh, that bone looks a little lighter than the other bones, so that one must be thinner? And no, we don't. We use a bone density test. And what's a bone density test? Bone density test is a type of x-ray, but, and do I have an eraser? I do have an eraser. This is what it's like in my office. I just draw and erase. All right. We use a scale. 0, positive numbers, and negative numbers. So anything 0 is normal bone density. Positive is strong bones, you know, young kids, teenagers. When we get into the negative numbers, that's when we are worried. So if you go from 0 to -2, we call that osteopenia. And actually, it goes farther than that, so I lied. It's to -2.4. It's just the number I see most is -2. When you go from 2.4 to -2.5, 2.5 is osteoporosis. And that's the objective way we measure it. But we have other criteria. If we have somebody who is osteopenic and then develops a fracture, doesn't matter how they develop the fracture, if they sprain their ankle and break their fibula, if they just get a compression fracture. Osteopenia plus a fracture we call osteoporosis. So it means that your bones are just not strong enough to withstand that normal stress. And what do these numbers represent? It's a comparison. When you get a bone density test, if you've ever had one, if you get the report, you actually get two different scores. You get a T-score and a Z-score. The Z-score is when they match you against people in your own age group as to what your bone density is and what age-related comparison is. A T-score is matched against young, healthy people, and that's what these numbers represent. These are a T-score. So they compare our bones to people in their 30s. It hardly seems fair, doesn't it? But so be it. That's what our definition is. So who gets osteoporosis? Postmenopausal women. Women who've had their ovaries removed at a young age and did not take hormone replacement. Men who are postmenopausal, and not many people think about men being postmenopausal, but older men will get osteoporosis. White women are more likely to have osteoporosis than Hispanic or African Americans, especially thin, light-haired women. And it can be genetic. It can run in families. We can get it from different types of diseases, any chronic disease. Kidney disease, liver disease, rheumatoid arthritis, lupus. Anybody who's taken steroids for anything in particular can develop osteoporosis. The diabetic is more prone to osteoporosis. People with thyroid dysfunction are more prone to osteoporosis. Parathyroid dysfunction is a big one, but we'll kind of talk about that a little bit later. It can be genetic, can run in families. Young people can get it who have, osteogenesis imperfecta. They can have osteoporosis. Young women who are very athletic and very low body mass, and they don't have a lot of fat and they don't have a lot of estrogen, if they don't get their periods and they are amenorrheic, they can get osteoporosis at an early age. And a lot of young girls don't think that that's an issue. But I remember reading a study when I was back in residency, did a study on gymnasts. When most of the gymnasts were not as muscular as they look these days, like the Nadia Comaneci, they did bone density studies on their vertebrae. And at their age, they had the vertebrae of 60-year-old women because they were amenorrheic for so long. Yeah, it was crazy. So now you see the gymnasts, they don't have the same body types. They're all stockier and muscular, they're stronger, and so I bet they don't have nearly the same issues that those thin, skinny girls used to have. Medications, medications are just a huge cause of osteoporosis. Steroids tops the list, but it can be blood thinners, people who are on heparin, Coumadin, they can get osteoporosis. Too much thyroid hormone can cause osteoporosis. Seizure medicines, things like Dilantin, phenobarbital. Oh, I have a whole list. Let's see. Oh, reflux. All the proton pump inhibitors, Prilosec, Nexium. And people don't realize that those can cause osteoporosis, and that's a huge cause. The breast cancer drugs, the things that you hear, aromatase inhibitors, they can cause osteoporosis. Chemotherapy. People who are on or have had transplants and they're on the anti-rejection medicine, all of that can cause osteoporosis. In the big scheme of things, do we ever not give somebody medicine because they're going to get osteoporosis when we are dealing with transplants or blood clots or things of that nature? Of course not. We always treat the most severe condition first. But knowing that that can be a side effect, it's nice to be aware. A couple of the diabetes medicines, Actos and Avandia. And there's not as much Actos around as there used to be, but they can cause osteoporosis. So really a whole host of medicines can contribute to osteoporosis. Habits, smoking, too much nicotine, too much caffeine, too much soda pop, all of those bad habits can lead to osteoporosis. Does osteoporosis shorten your life? No, it does not. Are you going to live less because you have osteoporosis? No. But can it cause complications that can lead to you having a shorter life? Yes. And this is where we talk about how it can affect you and what you can do to help it. The number one condition that affects our bones is immobility. If we take normally active people and make them very quickly immobile, your bone density decreases tremendously. If I use a young male as an example, take a male who gets into a trauma, whether it's a spinal cord injury, a multi-trauma, and we lay him in bed, and either he's casted or he can't move because he's paralyzed, is paraplegic. His bone density diminishes rapidly in the first 2 to 4 weeks. The calcium literally flies out of his bones. I can't describe it any other way. We take a young boy, we make him immobile. Sometimes within 2 weeks, his serum calcium level is so high because his bones are not being exposed to gravity, and the weight bearing and muscle activity on the bone plays a huge role in the whole calcium metabolism. So immobility is a huge cause of osteoporosis. And if we think about the aging process and the chronic conditions that we mentioned, all of those have immobility associated with it. So if you take immobility on top of the underlying medical conditions, then your risk for osteoporosis just increased 10, 20, 30-fold. It is unbelievable. It is why in the hospital, when you think everybody is being so barbaric about getting you out of bed and moving you, it's to really decrease the side effects of immobility. And immobility is really a talk in and of itself about how it affects us metabolically. But just in terms of our bones, it really increases our serum calcium levels and decreases our bone density. So by being immobile, you increase osteoporosis and increase your risk of fractures. And then what happens if you develop a fracture? You become more immobile. So it becomes a vicious cycle. So it really is the reason we want to keep moving and exercising. Are there medicines that help osteoporosis? There are. Most of them help to maintain bone density. Not many of them increase bone density. So all the commercials you see, and I'm probably not supposed to use brand names, but it's easier than using all the generic names, but all the commercials you see, Fosamax, Actonel, Boniva, and Reclast, those are all basically in the same class of medicines. Some act a little shorter, some act a little longer, some are given by injections. They all maintain bone density. None of them increase bone density. So when you're on this scale, regardless of where you are, -2, -2.7, -3, -4, any of those medicines will just maintain bone density. The problem is those medicines have been around the longest period of time. That's all the insurance companies want you to take. So every insurance company wants you to take Fosamax before you do anything else, or Actonel. But if you are somebody who already has fractures, we are already thinking, gosh, we want to improve your bone density. We don't just want to maintain. And there are really only 2 medicines that improve bone density, and they are, and I'll leave that on there, Prolia and Forteo. They're the only 2 medicines which have been shown to increase bone density. Prolia is a little bit easier to get authorized through insurance companies. Obviously, it must be less expensive. It's given twice a year, just as a little injection, like a TB shot. What is it? It's a protein inhibitor. The name of the protein is called Renkel protein. And it is a protein that builds up the cells that break down our bones. So we inhibit that protein. And by inhibiting that protein, we decrease the cells that break down our bones. So the things that you do in your lifestyle to help your bone density can work because this is stopping it from breaking down. So it is a fairly good medicine. I've taken care of quite a few younger women in their 50s with osteoporosis, it takes about 2 years to really see a change in that bone density. So it really takes about 2 years on the medicine, you know, having good dietary and exercise habits to increase your bone density. Forteo. Forteo works the best out of any medicine, and it is called recombinant parathyroid hormone. And the parathyroid hormone is the hormone that is responsible for our calcium and phosphate metabolism. It is also a hormone that works together with something called calcitonin. And you may all know about calcitonin nasal spray. We used to use it lots years ago, but by itself it doesn't really do anything to our bone density, so we don't really give it much anymore at all. But parathyroid hormone is the hormone that is responsible for the whole calcium and phosphate metabolism to make our bones strong. So when I have somebody with osteoporosis and I'm doing a metabolic workup, one of the first things I do is try to look at the parathyroid hormone level. It's rare to really get somebody who is hypoparathyroid, but you know, I get a couple a year. And it's very important because then we can get the insurance company to really pay for Forteo. Forteo is different. You have to take it every day for 2 years. And it's given as an injection, like an insulin injection. But it's not such a bad thing because the needle is so tiny, it's hardly painful at all. I'm the person who likes to be able to stop things if you're having side effects. So sometimes people are overwhelmed when they hear, oh no, I have to take an injection every day. But really it's kind of nice. If you have an adverse reaction, you can just stop it, as opposed to the once-a-year injection or even the every 6-month injection. If you have a side effect, you just have to wait for it to wear off. Where the daily injection is much easier. You can just say, okay, I'm done with it. We can only give it for 2 years, though, and it's based upon the studies that were done on Forteo. They did studies on rats, and every rat that got Forteo got a certain type of bone cancer called osteosarcoma. Here comes Bernadette. And the osteosarcoma is a very bad bone cancer. So they started doing all of the research, and they said, oh no, we can't give this to people. Well, they chose the wrong animal as their study. Rats have very active bones. Their growth plates never close. Their bones are just turning over all of the time. It's how they get through spaces they should never get through. So what they found was that their bone metabolism is different than other animals' bone metabolism. So then they did a few other animal studies quickly, and those animals did not get osteosarcoma. They got the FDA. How they ever got the FDA to give them approval, but they did, to do human studies. So they started doing human studies. They did not choose any person that had any type of cancer ever. And nobody developed any osteosarcomas, nobody developed any bone cancers. So they said you can only give it for 2 years for risk of developing any type of cancers, and you can't ever have a history of any underlying cancer. And that's what limits our use of Forteo. I have a patient who begs me to give her more Forteo because she did the 2 years, her bone density went up, she had no side effects. And I can't. I said, no, we can't do that. So then we just try to maintain her bone density where it is. So that's what the medications do for osteoporosis. Do all medications have side effects? Sure they do. Do they have it in every person? Nope. 2 of you sitting here, one of you may take one and do very well, and one may take the same medicine and do terribly. The worst thing is for one person to say to another person, oh, I took that, don't take that, it's a terrible medicine. Because it's so different person to person. You really have to let your physician try and guide you. And I really say that the medicine sheets you get with your medications, you have to remember those are legal documents, not medical documents. Those are documents meant to protect the drug company, not meant to give you all of the medical information. So they're there to tell you that during that study, any complaint that any person had while they were taking the medicine, within that 6 weeks of the medication trial, is listed as a potential side effect. So, you know, you could get a cold when you're on a medicine. You could sprain your ankle when you're on a medication. If somebody sprained their ankle while they were on this medicine, they say, you know, sprained ankle 1%. That's how those numbers come to be. It doesn't necessarily mean that is a potential side effect. So you have to take that with a grain of salt, and that really is where your doctor fits into the picture. And just always remember, taking a medicine is not like going to prison. If you don't like it, you can stop it. You don't have to keep taking it. So sometimes if you need to try something to improve your condition, you can always try it and you can always stop it. So that's why we start with the medicine, but the most important thing is what you can do for yourself, which is diet and exercise, because that is what can improve your bone density. So if the medications maintain your bone density, except for Prolia and Forteo, then what can you do? And it is diet and exercise. And diet is all about calcium-rich foods and vitamin D-rich foods. And calcium-rich foods are your dairy products, your dark green vegetables. I have a whole list because some of them are ones we don't even think about. Oh, almonds and sardines. No wonder I didn't remember those two. Those are foods that you just wouldn't even think have calcium in it, but those are high calcium foods. And our calcium is much better absorbed from our food sources than it is from supplements. So the recommendation still exists that any woman over 50 should take anywhere from 800 to 1,200 milligrams of calcium a day. But the studies also showed that if we do it only by supplementation, if all we do is take a calcium supplement, it doesn't increase our calcium levels or our bone density very well. And if anything, somewhat harmful. Increasing our calcium supplements, what do we tend to do? We tend to get calcium deposits in the arteries in our heart. Yes, and this was a very difficult thing even for me to do. I have osteoporosis that runs in my family, and I was taking calcium since I was in my mid-30s because I said, Mom has osteoporosis. I'm light-haired, light-eyed, small-boned. When I read those studies, I did not stop taking my calcium. I kept taking my calcium. Every day I took that calcium. I go, you know, you shouldn't do this. Every day I took it. Finally, I said, oh gosh, what would I tell my patients? I would say you need to stop that calcium supplement because it increases risk of heart disease. And we have heart disease in the family, so I had to weigh the two. So it was a very difficult thing to do to stop my own calcium supplements in the face of osteoporosis. But what else did the studies show? They showed vitamin D is the more important supplement for us to take. That is what our bones really need. So if you try to increase the calcium in your diet, so your dairy products, your fortified orange juices, your cereals, all of those, your vegetables, and then increase your vitamin D in your diet, but also supplement your vitamin D, that's better for our bone density than just calcium alone. And truly, the literature on vitamin D over the last 2 years has really been explosive, for lack of any other word. It is out there in the cancer world. Vitamin D plays a big role in prostate cancer in men and vitamin D deficiency. Well, remember what vitamin D deficiency is in kids. Everybody knows what it is, right? What is it? It's rickets, right? And so it's low bone density, joint pain, and muscle pain. Well, in our part of the country, where we are not getting enough sunshine to make all the vitamin D in our skin, our vitamin D levels are very low. And we're inside most of the time. So the only place our body makes vitamin D is in our skin. And you need ultraviolet light to make your vitamin D. So I am seeing people with incredibly low vitamin D levels. Our normal vitamin D level should be between 30 and 100. I'm seeing young people with an 8, or I'm seeing people with 14s and 16s. And some of their complaints are aches and pains and joint aches and pains and muscle aches and pains. And my first case of vitamin D deficiency, that I ever diagnosed was in a young woman with numbness in her hands. And her doctor sent her to me for EMG and nerve conduction studies, and they were normal. I bet I did studies on her 5 times in 1 year. I just almost couldn't believe every time she came through the door. And they were normal, normal, normal. There was nothing abnormal. And she was miserable, and makes you think, is her symptom really there? Is it not there? I finally said to her family doctor, why don't you just test all of the things that could give someone neuropathy and see what shows up? And I said, throw in vitamin D and vitamin E. Her vitamin D level was like down about 4. As soon as we replaced her vitamin D, her symptoms went away. So she had nerve symptoms from the deficiency without nerve damage. But it is vitamin D deficiency can cause neuropathy. So it was the first time that I said, I wonder what else this does. And it really cued me into looking for vitamin D deficiency with other types of conditions. And now there's just a lot more research on it. So your foods with vitamin D, there are not nearly as many foods with vitamin D. Your oily fishes, your salmons, your mackerels, your herrings, things like liver, like beef and calf liver, they have a lot of vitamin D. Eggs, mushrooms, but certain mushrooms, the mushrooms have to be exposed to the sun. And how do we know that? I have no clue how we know if the mushrooms were exposed to the sun or not. So those mushrooms have vitamin D in them. Let's see, what else? Oh, all of your fortified foods. Your milk has vitamin D, your orange juice has vitamin D, your cereals, your breads, and that's why the food manufacturers added calcium and vitamin D all those years ago, was to help the children who had rickets. That was where all the fortification came from. So those are all very important pieces of information. But the other thing that you can do in your diet to help your bones is protein, and it's the biggest area where women are deficient compared to men. We should get 46 grams of protein in our diet a day. Men should get 56 or more. Not many women hit 46 grams of protein a day. Most women get their protein in their evening meal. They'll eat chicken or fish, and then, you know, they do their vegetables and their green vegetables, and everybody's going low on carbs and all of that. 46 grams of protein is a lot to get. And why do we want lots of protein? The protein does not get deposited into our bones. It's for our muscles. In order for those bones to be strong, the muscles that work on them have to be strong. So it's the muscles that continually pull against the bones that make the whole calcium and phosphate metabolism take place. It's why the example of the immobility occurred. It's why taking that young active male and laying him in bed, why the calcium just flew out of his bones, because his muscles just literally stopped working on the bones to help the whole calcium metabolism. So diet is calcium and vitamin D in your diet, and supplementation with the vitamin D, as well as trying to increase the protein in your diet so that you get stronger. So that's the dietary part of it. And then the exercise is very important. And the exercise needs to be weight-bearing exercise. Swimming, we always say, is such a great exercise for all of us as we get older. It takes gravity out of the picture. It helps back pain. It helps arthritis pain. It does not help osteoporosis because it puts us in a weightless environment. So we truly need gravity in order to help our bones. So you can do low impact or high impact weight bearing. High impact only for those without joint problems. But low impact exercises like walking on a treadmill, elliptical, stationary bicycle. It's just because when everybody sits on the bike, they kind of go back and forth. They go back and forth, and they don't use good mechanics, really. It's poor bicycling mechanics, but it's good for your back. So stationary bicycle gives you strong back. Really, walking and the other aerobic exercises are best for your bones. Anything that you could do impact-wise, so if you could do a little jogging or anything like that, that's always better for your bones. Lifting weights is very good for your wrist and upper body, so doing dumbbells. Doing planks and push-ups, very good for your bones in your wrist and your arm, because we forget the fall when we put our hand out. and the thin bones will cause us to have wrist fractures. So any upper extremity exercise with weights is very good for your bone density. So exercise is the most important thing. And there's all different types of recommendations for how much to do and when to do them. And you're going to hate everything I say when I talk about exercise. Because is 2 times a week enough? No. Is 3 times a week enough? No. The recommendations for exercise now are 6 to 7 days a week of exercise. And if we talk only about cardiovascular fitness, the cardiovascular recommendations are 30 to 45 minutes of cardiovascular exercise 5 to 6 days a week. It used to be 20 minutes 3 times a week, and that was good. And that is not the recommendation anymore. It's nope, you really have to get that heart rate up, and you have to do it every day. And for bone density, I mean, I'm going to go right out there and say you can do weight-bearing exercise every day. I think it's good for people to take 1 day off a week, just because it lets muscles relax, it lets joints relax, it lets everybody get a break from exercise, because exercise is not fun. No matter what anybody says, exercise is not necessarily fun. There are active things you can do that are fun, but they are not necessarily truly considered exercise. So being active is good. Exercising is very important. And you know, these days with things like Mind Body Wellness, where they have places to come and exercise, YMCA's fitness centers, I think we have more at our disposal than we ever did. And this is probably one of the areas that some of the insurance companies have done well at when they have their programs like the Silver Sneakers program, and they have other names for them, where they'll pay for your YMCA membership as opposed to going through physical therapy. Well, that's a great thing. They're paying to let you exercise, and I think anybody who doesn't take advantage of that really is missing a very good opportunity to stay a little healthy. Because almost all of the fitness centers that participate in that have trainers that help you begin your exercise program and see what you can do and what you can't do. So they don't ever throw you in over your head. So I think anytime you can take an advantage of an exercise program, you should. What have I missed since I didn't have my slide? And it's, instead of being deposited as calcium phosphate in our bones, the phosphate in the soda pop draws the calcium out of our bones. So it is a huge contributing factor, as well as kids' immobility. Kids are so much more sedentary than they used to be. So they just are not outside, they are not in the sun, they are not in shorts and short sleeve shirts, they are inside, they are, even a lot of their organized activities take place inside because of where we live. They just get many fewer nice weather days to be outside, and you know, they're not allowed to roam as free as we used to when we were kids. So that plays a huge role in those low vitamin D levels, and I'm seeing it a lot more in adolescents than ever before. Yes?
When do you start to consider whether you need medication, at the osteopenia, or do you wait until you actually get to the...
It depends upon the person and their lifestyle and what's been happening. If I get the person who has osteopenia and has a really terrible lifestyle, they smoke, they drink only coffee and alcohol, they don't do any exercise, and they don't eat many fresh vegetables, we try to change some of their lifestyle habits first, because then that can improve their bone density. But if we get the person who is doing everything and they say, I eat this many dairy products every week and I exercise 5 times a week, and unfortunately I had my ovaries removed, that person I would say, yep, we need to go on and maintain your bone density right now. So it really is case by case as opposed to just a standard number. We always want to try to contribute to osteoporosis. And so it really is a difficult situation to be in. And that's why you really need to work with really your gastroenterologist, because there are newer medications out for reflux as well. And I don't know all of the literature on what those side effects are. But if you're somebody who's been on those for a long time, and you still have the reflux and you want to take the osteoporosis medicines, I think that's a real brainstorm with your gastroenterologist to say, what else can we do besides these medicines?
No,
because
that's a very good
question. Magnesium is a very important element for lots of different parts of our body. Magnesium plays a bigger role in our blood vessels and our muscles than necessarily our bones. So magnesium replacement, and you can take a magnesium supplement, but magnesium is its own animal. If you went to Kmart or Walmart and you wanted to get a magnesium supplement, you are almost always going to get magnesium oxide, just because it's easy and it's cheap. It's not well absorbed from our body. It's what's in milk of magnesia. Hence, it's not well absorbed. That's what makes milk of magnesia work. The magnesium that works well, they're all different forms of it. They all end in ATE. And so it's magnesium oxalate, magnesium gluconate, magnesium stearate. There is magnesium sulfate, but magnesium sulfate can make your muscles almost too relaxed. That's what we give to women when they go into preterm labor. It's like a smooth muscle relaxer. And these used to be very hard to find. They're easier now. They're much easier to find. You can go to GNC and they sell one that's called the super magnesium, and it's a combination of 3 or 4 different chelated magnesiums. Those are the magnesiums that are more easily absorbed for our body. They're good for our heart, they're good for our blood vessels, they're good for migraine headaches, good for our muscles. Not so much do they play a role in osteoporosis. That's more a myth you hear out there. But it is a good supplement nonetheless. All the cardiologists have all their patients taking magnesium these days. D3 is what our bones need more than anything. So when you go to get a vitamin D supplement, you want the vitamin D3. And it's just how many hydrogen peroxide ions they have hooked to it, but it's the D3 that makes our bones stronger. So when you look for a supplement, you look for vitamin D3. And we didn't talk about dose, did we? Did we talk about dose of vitamin D? No. If you get your calcium and vitamin D, that would be like your Citracal. If you went and bought Citracal, they almost always come as 600 milligrams of calcium and 400 international units of vitamin D. You really want to be taking, I say anybody over 50 should be taking 1,000 international units of vitamin D per day. And it may not be enough. I mean, we really do have to get our vitamin D levels checked to know if that's good or not. I get people who say to me, oh no, well, I take it every day, but then we check their vitamin D level and it's still low. When we replace vitamin D, it takes a while to replace those stores. We replace fairly aggressively. Somebody who comes in with that level, say, and I'll use 20 as an example. If somebody comes in with a level of 20, I give them 50,000 international units a week for 5 weeks. And then we recheck a level. If you get up into the normal level, then I say we either maintain at 1,000 or 2,000 international units a day. Vitamin D is not benign. Vitamin D is a fat-soluble vitamin. Can you get vitamin D toxicity? Yeah, you can. It stores in our liver, and if you get too much, you can get signs of jaundice and liver failure. So it really is important to know what the levels are and to take the right amount, not just to go out and take way too much. So I take 1,000 international units a day, give my husband 1,000 international units a day. And yes, we need to get our levels checked. we're delinquent, for lack of a better way to say that. But I do think it's a very important part of our overall health. No, and most of your non-steroidals really don't affect our bones from that standpoint. It would be nice, but that would also be like the commercial where 1 piece of broccoli a day, 1 sit-up. Interval training is very important though. In your normal exercise, What happens is we all accommodate to our normal level of activity. So, if you're sedentary and you begin exercising, you need to do less physical activity to increase your metabolism, to lose some weight, to feel stronger than somebody who may already be conditioned. And we all find it very difficult to work harder or to get stronger. But the research on exercise is phenomenal. When I studied for my rehab boards 2 years ago, and we hate to study for boards because who wants to study what you know, right? You know it, you don't have to study it. Okay. The research on exercise blew me away on what happened in the last 10 years. Because of insurance companies, really, because of insurance companies mandating that we prove what we say, that we only tell you what's in the literature, and that there's evidence behind it. In my field, that's very difficult. We're in physical medicine and rehab, so we use modalities and exercise. How do we prove that? Well, they are doing buku research. Well, the research on exercise is taking place at the cellular level to say, is exercise doing what we say it does? Is it lowering your blood pressure? Is it lowering your blood sugar? Is it strengthening your bones? Is it doing the things that we say it does? And so far the answers are yes, it does. And now the questions are, well, why? Why is it doing what it's doing? And are there times that it's harmful? So is it always good or no? Are there some times that it is bad? And I'll go back to my spinal cord injured patients. We start moving spinal cord injured patients right away in the intensive care unit. We start moving everything. And in spinal cord injured animals, they're showing that actually if we do exercise right away, we may be increasing all the inflammatory markers in their system instead of the ones that decrease inflammation. But if we wait about 2 to 3 days and then do it, we don't have that same response. So they're trying to find out, like, is there a timing? Is exercise harmful if we do it too soon? But the exercise research blew me away, and particularly one study. There was one study that took people of every decade, 40s, 50s, 60s, 70s, and 80s. They had the same number of participants in each of the study groups. They all had medical conditions: arthritis, COPD, peripheral arterial disease. They asked every one of those people if they thought they could exercise any more than they already did, and everybody said no. No, I can't. I get short of breath. My legs hurt. My back hurts. I can't do any more. They all agreed to go into an 8-week exercise program that was set out for them, and it was more than anything a progressive walking, endurance, and a little bit of strengthening program. Very few people dropped out of this study. At the end of 8 weeks, every person in the study, regardless of their underlying condition, improved their walking endurance, their distance to walk, and the time of the onset of their symptoms. So they didn't eliminate these conditions, but the person with COPD was able to go farther before they had shortness of breath. The person who had peripheral arterial disease was able to walk longer distance before they got cramps in their legs. The person with arthritis was able to do a little bit more before they had their knee pain. So the study was unbelievable, particularly since it spanned the decades. And the conclusion was, who would not want to be stronger? So your minute of exercise does help everybody at the current level of conditioning that you're in. So if you're at a current level of conditioning and you do 1 minute of, as I guess I can't say that on the video, of crazy exercise for 1 minute, you will be in better condition 30 days down the road than you are now. With your current exercise program, any amount of interval training is very helpful. So if you have a 30-minute exercise program and you've been doing it for 3 years, say every day you do the same aerobics and you're healthy and your blood pressure is good, if you just change up that 30 minutes a little bit, where after 3 minutes you do a minute interval, and then you go back and you do 3 minutes, and then you do another minute interval, and you do 3 minutes and another minute a little faster. That's what increases your strength and conditioning more than anything. So they probably are right in saying that 1 minute of exercise will help you to be stronger or better than you were, but it still doesn't give you the same as doing your 45 minutes of exercise. And these days, a lot of the recommendations are just really geared towards the fact that everybody is so incredibly sedentary, and if we can get anybody moving a little bit. So all of their recommendations are correct when they say it's better for you to go up and down the stairs and to walk farther from your car. That is all excellent advice. It just should not replace exercise. It should be in addition to exercise. Exercise should be in addition to your daily activity. I had a woman in my office the other day, some very inspiring people sometimes. She lost over 100 pounds in the last year. She by no means has any athletic appearance to her whatsoever. She's 67 years old. She started doing CrossFit exercise. She's overweight. She has arthritis. She started CrossFit exercise, and the trainers are very good. You know, they start people at what they can do. But she said the primary thing is they began me with very good body mechanics, doing everything appropriately so that she didn't get hurt. And she said she was in there last week at a CrossFit exercise, and there are people in all types of conditions, and the trainer says, okay, for 30 minutes we're going to do, and it was a combination of deadlifts with a bar, push-ups on the floor, and a few other things, and they do a couple of aerobic things in between. She said at the end of the 30 minutes, she did something like 45 deadlifts and 40 push-ups, because she did them like 2 at a time, and then they go and do something else. But if you ever imagined saying to a 67-year-old a year ago, I think you should lift weights and I think you should do 40 push-ups, she would have never done it. And she said she was just embracing it because she felt so good. She felt good. She lost weight. Her pain was better. So that was kind of the extreme example. But it fits in the we are never too old to get stronger or to do better. And I think that's the overall theme. And we went away from osteoporosis there. Sorry.
Any other questions? Well, thank you very much.
You're welcome.
For a conversation